Dr. Thiyagesa Deva Ganapathy, MBBS, MD, Respiratory Medicine, Fellowship in Intervention Pulmonology, Educational Background, Graduation and Post-Graduation. He completed his MBBS 2014, Sri Venkataeswara Medical College and Research Institute, Pondicherry. He completed his MD, Respiratory Medicine, 2019 Mahatma Gandhi Medical College and Research Institute, Pondicherry, Sri Balaji Vidyapith University, Pondicherry. He completed his Fellowship in Intervention Pulmonology, 2021, Yashoda Hospital, Secunderabad. Academic Achievements and Awards. Gold Medal in MD Respiratory Medicine for Academic Excellence in University Level. Best Paper Award. Intra-College Paper Presentation in Mahatma Gandhi Medical College and Research Institute 2018. Presented Case Report in Pondicherry Chest Society. Distinction in Human Anatomy in First MBBS Examination. Distinction in Microbiology in Second MBBS Examination. Passed all examinations in first attempt. Procedure expertise. Bronchoscopic procedures. Diagnostic bronchoscopy. Therapeutic procedures. Endobronchial ultrasound. Conventional EBUS. Radial EBUS guided procedures. Rigid bronchoscopic procedures. Endobronchial tumor debulking. Tracheal stenosis repair, tracheal stenting, foreign body removal, transbronchial cryo-lung biopsy, pleural procedures, thoracoscopy, rigid and flexi-rigid procedures, intercostal tube drain insertion, IPC insertion, participation at various symposiums, WORKSHOPS, participated as delegate in workshop on rigid bronchoscopy on DEC 2020 in Yashoda Hospital, Secunderabad. Participated as delegate in workshop on endobronchial ultrasound on March 2021 in Yashoda Hospital, Secunderabad. Workshop on Access, Diagnose and Treat -2019 conducted by the Department of Pulmonary Medicine, Royal Care Hospital, Coimbatore on Advanced Bronchoscopy Diagnostic Techniques on April 1, 2019. Attended CME conducted by Pondicherry Chest Society every quarterly. Attended CME conducted by Department of Pulmonary Medicine, Mahatma Gandhi Medical College, Puducherry and International Congress of the Pulmonologists Society of Indian Ocean in DEC 2017. Completed BLS and ACLS course October 2016. Attended Common Pediatric Surgical Problems Workshop on Central Venous Line conducted by IAP Vilupuram. Dissertation, Assessment of Spirometry Severity in COP patients and its correlation with high-resolution CT findings under the guidance of Professor Dr. R. Paginival, Professor and HOD, MGMCRI, Puducherry, via PER, poster presentation at National STATE conferences. Title, All the Wheezes Are Not Asthma, Endobronchial Tuberculosis, presented at CRSCON, conducted by Coimbatore Respiratory Society in 2017. Title, Case Series of Whiteout Lung presented at MGMCRI, Puducherry on TAPCON 2017. Additional activities and experience. Teaching for undergraduate medical students and postgraduate junior doctors. During post-graduation, professional memberships. Life member Indian Chest Society. Life member in the Malaysian Association of Bronchology and Interventional Pulmonology. Life member in the World Association of Bronchology and Interventional Pulmonology. Member in European Respiratory Society. IMA lifetime membership. Dr. Thiyagesa.
Good evening, everyone. Thanks for the warm welcome. My today's presentation is interpretation of pulmonary function tests. So, the objectives of today's presentation is we'll learn about indication of pulmonary function test and some physiology about pulmonary function test, like lung volumes, and we'll have an organized approach to interpretation of pulmonary function test and to identify obstructive, restrictive, and mixed pattern of obstruction in pulmonary function tests. Pulmonary function test is a term which is used for some studies or maneuvers that is performed using some standardized equipment to measure the lung function. PFT measures respiratory mechanics, lung parenchymal function like gas exchange and cardiopulmonary reactions. The common indications of pulmonary function testing are it helps us to evaluate the symptoms of like chronic persistent coughing, wheezing, dyspnea, and chest pain. For objective assessment of bronchodilator therapy. In case if you are starting a bronchodilator therapy for a COPD and asthmatic patient and you want to know the prognosis of how the treatment is working on it, we'll be able to assess through pulmonary function tests. And for processing the presence of disease in a patient with known risk factors such as smoking. If a patient comes to our clinic with a history of smoking and we are evaluating for other disorders like cardiovascular disease conditions, doing a PFT will help us to give us the current lung status of the patient. And for evaluation of the effect of exposure to dust or chemicals at work, like occupational lung diseases, we get to know what is their lung status. Preoperative evaluation for a patient who is undergoing thoracic or upper abdominal surgeries. All the patients who are undergoing thoracic or upper abdominal surgeries need to undergo this pulmonary function test to know the lung result. This will help them to prevent the post-operative lung atelectasis changes in those patients. And for objective assessment of impairment or disability. So, pulmonary function test helps to classify the lung disease into 3 categories. There are obstructive lung diseases, restrictive lung diseases, and pulmonary vascular diseases. Obstructive lung disease like COPD, it ranges from chronic bronchitis to emphysema, asthma, bronchiectasis, and cystic fibrosis. And the restrictive lung disease of interstitial lung disease, chest wall pathology like kyphosis, scoliosis, and obesity, and neuromuscular diseases like ALS and muscular dystrophies. And pulmonary vascular diseases are primary pulmonary hypertension and chronic thromboembolic diseases. We'll go into a little bit of physiology before going to the main interpretation of PFT. The lung volumes and lung capacity refers to the volume of air associated in different ways with respiratory cycles. The lung volumes are one which is directly measured by pulmonary function test, and lung capacities are inferred values from these lung volumes. There are 4 lung volumes, which is inspiratory reserve volume, expiratory reserve volume, tidal volume, and residual volume. You all will be familiar about this graph. The normal breathing inspiration expiration is called as tidal volume, which is 500 ml. From the point of our normal tidal inspiration to the maximum amount of inspiration is called as inspiratory reserve volume. Pointer. I was just waiting for the pointer.
So you use the mouse until they find it.
I'm not able to find one of there.
They continue, you can understand.
Yeah.
All of us know PFT.
So, from the point of tidal inspiration to the maximum amount of air which we can inspire is called as inspiratory reserve volume. And from the point of tidal expiration to the maximum amount of air which we expire is called as expiratory reserve volume. And the amount of air which is present in the lungs even after maximum expiration is called as residual volume. So, these are the main volumes which we can calculate from PFTs. And the capacity is like the vital capacity is the total of inspiratory reserve volume, the tidal volume, and expiratory reserve volume. And the functional residual capacity is the total of expiratory reserve volume and the residual volume. And the total lung capacity is total of all these volumes like inspiratory reserve volume, tidal volume, expiratory reserve volume, and residual volumes. We have to know the basics of these volumes before going to this PFT. And these are some textbook definitions for all these volumes. The tidal volume is the amount of air inhaled and exhaled at rest. Inspiratory reserve volume is the volume measured from top of the tidal volume, the initial point of normal exhalation to maximum inspiration. And expiratory reserve volume is during expiration, the volume from the bottom of the tidal volume, that is from the point of expiration to the maximum expiration. And residual volume is the volume of air left in the lungs at the end of post expiration to the bottom of expiratory reserve volume. And these are the capacities. Inspiratory capacity is tidal volume plus inspiratory reserve volume. And functional residual capacity is expiratory reserve volume plus residual volume. And vital capacity is the total of inspiratory reserve volume, tidal volume, and expiratory reserve volume. And total lung capacity is of all these volumes. And there are a few lung volumes which will be calculated only by performing certain maneuvers. That is post-vital capacity. Post-vital capacity is after a patient has taken a deepest possible breath, and this is the volume of air which can be forcible and maximally exhaled out until no more air can be expelled. And this is the maneuver which we will be doing when performing a PFT. So we have to ask the patient to take a deep breath, maximum breath inside, and then we have to ask him to forcefully expel all the air outside until no more air is there in the lung to be expelled. So that is calculated as FEC. And FEV1 is post-expiratory volume in 1 second. So this is the volume of air which can be forcefully exhaled from the lungs in the first second. So that's FEV1. And PFR is the peak expirated flow rate. This is the max. When we ask the patient to take a deep inspiration and ask him to blow the air forcefully out, this is the maximum flow rate which is achieved by the patient during that maneuver. And FEF 25% is a measure. It describes the amount of air that was forcefully expelled in the first 25% of the forced vital capacity. And FEF 50% describes the amount of air expelled from the lungs during the first half of the forced vital capacity. And FEF 25-75 measures the middle half of the forced vital capacity maneuver. This FEF 25-75 is very important in diagnosing small airway lung diseases. This is the normal flow volume loop, and this is the volume time loop. When we get a PFT report with us, we'll be seeing these two graph patterns in the pulmonary function test. So the total from this the x-axis to the end of x-axis is the total lung capacity, and the place where this graph occupies is the vital capacity in the graph. And the difference between the end of this graph to the end of the x-axis is the residual volume. And when you see the flow time graph, you will see that around 80% of the air will be expired in the first second of the maneuver, and it will maintain a plateau followed by that till the end of the respiration, that is the post vital capacity. So we'll go for the stepwise interpretation of the pulmonary function test with the cases. So the initial part of the interpretation comes from the demographic data. So when you see a pulmonary function test, we'll be seeing a data like this, having the patient's name, age, height, weight, gender, and ethnicity. See, these all the data will be entered by us in the pulmonary function test, and the software will calculate a predicted value based on the age of the patient, height, weight, gender, and ethnicity. So for each and every patient, by after entering all these data, the system will generate a predicted value, and we will be asking the patient to perform this maneuver. So the percentage of FEV1 which we see in the PFT will be calculated by calculating this from the predicted value and the patient's performance status. So the demographic data is very important when we interpret a PFT. And when we see a graph of a pulmonary function test, we should know whether the PFT is interpretable or not. So for adequate quality of a PFT, these are the 4 points which is very important. That is, it should be free from artifacts like cough or glottic closure. It should be free from leaks, and the PFT should have a good start. And the patient should produce good effort when performing this pulmonary function test. When you see this left upper corner, this is the normal volume time graph, and this is the normal flow volume graph. But here, if you see the volume time graph, there is a dip in the volume time graph, and when you see the flow volume graph, there is a small dip coming here, and then the graph is irregular. So this kind of artifacts will happen when a patient is coughing when he is performing this PFT. So the next couple of slides we will go ahead with what are the inaccurate results which can happen when performing this PFTs. So inaccurate results from coughing, like we explained in the previous graph, there will be a small dip here which is coming in the volume time group and a dip here. So when a patient coughs while performing the PFT, that will interfere in the FEV1 value of it because of the forceful expiration which is happening during this cough. So inaccurate results from glottic closure. When a patient is performing PFT and a premature glottic closure is happening for him, so at that time there will be small bend happening in the volume time curve, and here usually the graph has to extend completely till the 6 seconds here. But if you see here, there will be a small dip in the graph which is happening at the end. So this will happen when he's having a premature glottic closure, and this will affect the plateau formation of the flow volume loop and will show false values in the lung volumes. And when we perform a PFT after forceful inspiration, when we are asking the patient to expel out forcefully, he has to expel continuously for at least 6 seconds. So if he has this early termination will happen when the patient expels only for less than 2 or 3 seconds. And inaccurate results from leaks will happen when the patient is breathing through the nose, or there is inadequate closure of the transducer in the mouth, or there is some leak in in the oral cavity, there will be having a long graph like this curve will be going there. So this will produce false values. And whenever we are performing PFD, the plateau formation is very important in the volume time graph to tell whether it is adequate or not. So these kind of artifacts will produce inaccurate plateau formations. Like the volumes will be shown as low volumes, but patient will be able to do better when we coach them like the menus properly. And inaccurate results from variable error. This is one of the common errors which we will see. Like when we ask the patient to perform a PFD, he'll be breathing multiple times when he's performing it. So that will cause artifacts like this. There's one more thing which is we have to see when interpreting this graph, that is reproducibility. So if a patient should be able to perform at least 3 graphs which is similar to the effort should be similar in all these 3 graphs, or at least less than 5% variability should be there in the FPC procedures. So if you see the graph, like if you leave at 5%, all the efforts are similar in these graphs. And this is the non-reproducible test. That you are seeing different levels of efforts which is seen here. So if you are asking a patient to perform a PFT, that is a minimum and maximum amount of times a patient can perform. A patient can perform minimum 3 times to maximum 8 times. So after 8 times, the effort which he is putting won't be proper actually. So if a patient is not able to perform similar pattern of graphs for 3 times, then the system will calculate 3 best graphs from the maximum effort what he is putting. And this is the normal flow volume loop and the volume time loop we should be getting at the end of all these numbers. So if you see in this PFD, there is an x-axis and there is an y-axis. So the graph which is there above the x-axis is the expiration loop, and the graph which is below the x-axis is the inspiration loop. You see there is a peak is seen in the expiration loop. So this peak will come only if the patient is doing this forceful expiration maneuver properly. And after this peak, the graph should come, it should be uniform without any artifacts. And inspiration will always have a loop pattern here. And if you see this volume time graph, you will see around maximum amount of error, approximately 80% of the air has been expelled in the first second, followed by the plateau formation should be there. And he should be able to expel till 6 seconds. When we go to the pulmonary function test changes in the obstructive and restrictive lung diseases, this is we'll have some small physiological explanation for it. So, in case of first we will see about the obstructive lung disease. In case of obstructive lung disease like COPD or emphysema, the main pathology is the alveolus of the lung will be expanded. So that is what emphysema. That's what we study as emphysema. The alveoli size will be more. And when a patient takes a breath inside, like whatever air coming inside the alveolus won't be completely expelled. There will be a small residual volume of air will be staying inside the alveolus. So when a patient takes this next breath, the air inside the lung will be added upon by the additional breath which is what he is taking, and it will further expand the alveoli. So the air which is inspired is not expelled completely in case of obstructive lung diseases. And this cycle will keep on happening, and the lung volumes will be increased in obstructive lung diseases. So if this is the normal lung volumes, you see in obstructive lung diseases, all the volumes will be increased because of chronic accumulation of air inside the alveoli and producing by increasing the surface of the alveolus. But in case of restrictive lung diseases, like interstitial lung disease, ILDs, there will be a fibrotic layer which will be forming around the alveoli, which is causing restriction of the alveoli to expand. So whatever air coming from inside will be in lesser volumes will be there compared to this obstructive and normal lungs. So in restrictive lung diseases, all the volumes will be decreased. So the flow volume loop in obstructive lung diseases, like if this is the normal flow volume loop showing expiration in the upper part of the x-axis and inspiration loop in the lower half, and this is the total lung capacity, and this is the residual volume which we see. And this is the normal flow volume time loop showing around 80% of air expired in the first second, followed by the FPC is maintained. If you see the flow volume loop in the obstructive lung disease. As we told, the residual volumes will be increased in case of obstructive lung diseases. See, this graph will be shifted towards the left side, showing increase in the residual volume, and you will be seeing a kink in the expiratory limb. This kink in the expiratory limb it occurs mainly because of obstruction in the airways, and the vital capacity will be decreased, but not so compared to restricted lung disease. It will be minimum decrease in the vital capacity will be seen. But if you see the volume time loop, as I told earlier, that in case of obstructive lung diseases, the air expired won't be it won't be complete expiration. A partial amount of air will be retained in the lungs. So the amount of air expired in the first volume will be only some 20 to 30%, and then the plateau will be maintained there, and LPC, but the post vital capacity will be normal in there. So the graph, so when you calculate this FEV1 by FVC, it will be less than 70% in the obstructive lung diseases. So when you go to the restrictive lung diseases, as we told earlier, the residual all the volumes will be decreased. So the graph will be shifted towards right side in case of restrictive lung disease, and the size of the graph will also be very small as the volumes are decreased compared to the normal PFTs. But in case of this volume time loop, if you see, the amount of air expired in the first second will be almost similar to the normal, and but the post vital capacity is decreased. So if you calculate the ratio of FEV1 by FVC, it will be either it will be normal or it will be increased in case of restrictive lung diseases. So this is the graph difference between the obstructive and restrictive lung. You see in the obstruction, the graph will be shifted towards the left side, and there will be a kink in the expiratory limb. And if you see the restriction, graph will be shifted towards the right side, and the graph will be small compared to the normal PFTs. There's a thing called as bronchodilator reversibility testing, which we do in PFTs commonly to see whether to differentiate between asthmatic or COPD. But if a patient is already on inhalation therapy, like we have been prescribing with bronchodilators, and we want to assess the status of current status of bronchodilator reversibility testing, we have to withhold the bronchodilator usage for the patient. These are the prescribed time limits for withholding the bronchodilators. If a patient is on short-acting beta agonist like salbutamol, we have to withhold using inhalers for at least 4 to 6 hours. And if the patient is on short-acting muscarinic antagonists like ipratropium, we have to withhold it for 12 hours. If the patient is on normal like formoterol and salbutamol, he has to withhold it for 24 hours. And if the patient is on indacaterol or verantoin, he has to withhold for 36 hours. And if he is on glycophenium and tiotropium, he has to withhold at least for 48 hours before performing the PFT for assessing the bronchodilator reversibility test. So, and this bronchodilator reversibility testing is like after withholding the bronchodilators, and we have to perform a baseline spirometry. After performing the baseline spirometry, we have to ask the patient to take 4 puffs of salbutamol or any short-acting bronchodilator which he is using it regularly. After taking this short-acting bronchodilators, he has to wait for 15 to 30 minutes for the drugs to act on. Only after that, we have to perform the post-bronchodilator reversibility PFT. So we will label the patient as having post-bronchodilator reversibility only if there is an increase in FEV1 value of more than 12% and more than 200 ml. It's not 12% or 200 ml. It is 12% and 200 ml. A patient should have both these changes to tell the patient is having proper bronchodilator reversibility. If either one of 12% or 200 ml is there, then we will label it as partial reversibility or minimal reversibility will be there. And these are the two bodies like gold and they are the main governing bodies for giving us guidelines for managing the COPD and asthma. So based on this gold and GINA guidelines, like for grading the patient's severity of obstruction, initially we have to look on the FEV1 by FVC value. If FEV1 by FVC value is less than 70%, then we will label the patient as obstructive lung disease. Once FEV1 by FVC is less than 70%, we have to look on the post-bronchodilator FEV1. It's not like normal FEV1, we have to assess the post-bronchodilator FEV1. In the post-bronchodilator FEV1, if it is more than 80%, we will tell it as mild. If it is 50 to 80%, we will rate it as moderate. And if it is 30 to 50%, 30% will grade as severe, and if it is less than 30% will grade it as very severe. This is for COPD and obstructive lung disease variants. And for grading respiratory defects, for a patient with restrictive lung diseases, the FEV1 by FVC value will be normal. After if FEV1 by FVC is normal, we have to look on the FVC value. For obstructive lung disease, we will be seeing FEV1 value. For restrictive lung disease, we have to see the FVC value. The FVC value is more than 80%, it is normal. If it is 70 to 80, it is mild. If it is 60 to 70, it is moderate restriction. And if it is less than 60, it is severe restriction defect. There are few other things.
What is FVC? Sorry.
It's forced vital capacity.
Forced
vital capacity. The vital capacity and forced vital capacity both are same. Only thing is we are asking the patient to perform forceful inspiration and forceful expiration. That is FVC. But based on the definitions, the both are almost same, except for the manual what we are doing. There are a few other things which we can diagnose by pulmonary function test, like presence of tumors in the airways or presence of any compression of the airway by the enlarged goiter or those things. So those things are graded as this variable extrathoracic obstruction, variable intrathoracic obstruction, or fixed airway obstructions. These are a few other things which we can diagnose in a pulmonary function test. So first we will see this variable extrathoracic obstruction. The airway extending from mouth to thoracic inlet is called as the extrathoracic airway. And the pathology in the airway before it is the pathology is mainly in the airway before entering the thoracic cavity, like tracheal tumors, goiters, or vocal cord paralysis. So in extrathoracic obstruction, the problem will be there in the inspiratory loop. You will see there is a flattening of the inspiratory loop in the graph. So if there is an obstruction in the extrathoracic airway, when a patient takes normal breathing inside, the airway pressure will be decreased compared to the atmospheric pressure. So there will be compression of airways will be there. But if there is a tumor inside, then the tumor will cause further compression of the airway and the inspiratory loop will be flattened. But when a patient is expiring out in case of these tumors, this expiratory air will form as airways linked in the airways and the airway will be maintained when it is expiring out. So there won't be any change in the expiratory loop. So if you see a graph pattern like a normal expiratory loop with there is a flattening of inspiration, then we have to suspect all these conditions, like that it can be present of tracheal tumors, goiters, or vocal cord paralysis. In variable intrathoracic obstruction, the issue is mainly in the expiratory loop. So examples like tumors in the lower trachea, tracheal strictures, and tracheomalacia condition. The lesion will be there inside the chest wall. So in these conditions, when a patient already inhales, the diaphragmatic and pleural pressure will be lost. So the tumor, if you see the pathology is there here. When the patient takes an inspiration, when the pleural diaphragmatic pressure is low, there won't be any obstruction in the airway when air goes inside. But when the patient expires out in these conditions, the pleural and diaphragmatic pressure will compress the lungs to help the lungs in expiration, and that will cause obstruction in the airways when it is expiring. So you will be having flattening of the expiratory loop, but the expiration loop will be normal in these conditions. So these are called as variable intrathoracic obstruction pattern. And there is one more entity called as fixed airway obstruction. Like tracheal and bronchial stenosis and tracheal tumors in the airways, will be having both flattening of the inspiratory and expiratory. This is called as a box pattern in pulmonary function test. This is the PFT interpretation strategy which we commonly follow. See, when FEV1 by FVC value, this is the first value we'll be seeing in PFT. If FEV1 by FVC is normal, then we have to look for the FVC value. If FVC is also normal, then we'll be doing DLCO. When the DLCO value is normal, then it is normal. If DLCO is decreased, then it is then the patients have high chance of pulmonary vascular disorders. But if FEV1 with the normal FEV1 by FVC and there is a decrease in the FVC, the forced vital capacity will decrease, then we have to look for total lung capacity. If total lung capacity is also decreased, then we will label it as restriction. But with normal FVC and if total lung capacity is normal, then we will more in favor of obstructive lung diseases. In the restrictive lung disease, we will be doing a DLCO. disease conditions. So with the restrictive lung disease, we will be doing the DLCO. If the DLCO is normal, DLCO mainly means diffusion lung capacity of carbon monoxide gas. If the DLCO is normal, then it is more in favor of chest wall and neuromuscular disorders. This DLCO works in a way that we will be asking the patient to expel the carbon monoxide gas, and we have to ask them to hold the breath for 10 seconds, and then we will be asking the patient to forcefully exhale the air. If carbon monoxide has high affinity to bind to hemoglobin compared to oxygen, so whatever carbon monoxide enters inside the airway will enter into the circulation. But if there is any problem in the alveolar capillary membrane, like interstitial lung diseases, then definitely there will be the diffusion capacity will be decreased in those cases. So that's how with the decreased FVC and if DLCO was decreased, it will be more in favor of IMA. But with the decreased FVC value, if the diffusion capacity is not involved, then it is more in favor of all the chest wall diseases like kyphosis, scoliosis, or any neuromuscular disease which is restricting the lung from expansion. So, but if the FEV1 by FVC value is decreased, then we will see the FVC. If FVC is also decreased, it will go in favor of mixed defect. But if the vital capacity is normal, then we will go in favor of obstruction. So, DLCO, this is just for theoretical quantum to differentiate between the obstructive lung diseases. If once we diagnose a patient as a case of obstructive lung disease, then if we are performing a DLCO, if the DLCO is normal, then it is more in favor of asthma. But if the DLCO is decreased, it is more in favor of emphysema. The main pathogenesis emphysema is destruction of the alveolar capillary membranes. So there will be interference in the diffusion capacity of carbon monoxide in these patients. So this is how we will systematically interpret the PFT. But what we have to remember is, initially we have to see the FEV1 by FVC value. If FEV1 by FVC value is decreased, then we will tell it as obstructive lung disease. If FEV1 by FVC is normal, then we have to look on the FVC. If FVC is decreased, we will go in favor of restrictive lung diseases. So these are the common things which we will be interpreting when we are looking at the PFT section. There is one more pulmonary function test which we commonly use is the peak expiratory flow meter. This is the peak expiratory flow meter. This which we won't be using it for diagnostic purpose, but in our regular clinical scenarios, we will be using this for a prognostic assessment in case of asthmatic patients. We will be giving this equipment to an asthmatic patient and we will be asking them to perform it in the morning and evening to calculate the diurnal variation of the airway obstruction. And then this graph shows the normal value of this PEFR for a particular age and a particular sex and height of the patient. These normal values will be different. But in our clinical practice, we won't compare the normal values like this. We will be comparing with the patient's personal best. When we are starting a PEFR for a patient, we will be documenting the patient best value for it. And then the asthma severity will be calculated like if PEFR is more than 50 to 75 of the patient best value, we will call this mild or moderate severity. If it is 33 to 50%, we will be labeling it as acute severe, and if it is less than 33% of patients best, we will be labeling it as life-threatening severity in asthmatic patients. So this is mainly used to assess the control of medications and the prognosis in the asthmatic patients. And diffusion capacity of carbon monoxide, like previously told, we will be asking the patient to inhale the carbon monoxide, and once the carbon monoxide enters into the bloodstream, it will be this is alveolar capillary membrane. So CO2 will be the carbon monoxide which we inhale will be absorbed in the blood cells. And based on the DLCO, the severity is class. DLCO can also be increased to the compared to the normal values. So the normal DLCO is 75 to 140%. There are conditions like primary pulmonary hypertension and pulmonary alveolar hemorrhages and diffuse alveolar hemorrhage where there is increased congestion in the lungs. Like there are increased blood cells which is circulating in the lungs. Sorry, this DLCO will be increased in those conditions. So mild decrease in DLCO is 60 to 70%, and moderate is 40 to 59, and severe decrease is less than 40%. This is how we will grade the diffusion lung capacity. these are the list of conditions where we will have increased DLCO and decreased DLCO. So the diffusion lung capacity of carbon monoxide increased in exercise and pulmonary hemorrhages, polycythemia, left to right shunts, obesity, asthma, and chronic bronchitis. Now all these conditions, the diffusion capacity will be increased because there will be increased blood circulating in the lungs. And DLCO will be decreased in post-exercise lung resection, emphysema lungs, interstitial lung disease, anemias, and pulmonary lymphangitic carcinomatosis conditions. So these are the conditions where DLCO will be decreased. We'll go to some case-based scenarios to just assess how PFT works. So in case 1, a 40-year-old man being treated with theophylline and clinical bronchodilators. So if you see the FeV1 by FVC value is 70%, which means FeV1 by FVC is decreased in this condition. And this is the pre-test and this is post-bronchodilators. If you see, if FeV1 by FVC is decreased, then we have to look on the FeV1 value. FeV1 value, we have to identify the difference between this pre and post. And percentage of change, we have it is 25%. So is there reversibility in this? Yeah. So FeV1 by FVC is increased by more than 12%, and the absolute increase is more than 200 ml in the previous year. So if you see here, the difference between this pre and post value is around 490 ml, and there is 25% change is seen compared to this pre and post value. So this shows there is reversibility in the this is case 2 scenario. A 53-year-old male present with breathlessness and cough for around 2.5 years duration, and he is an ex-smoker with a smoking index of around 350. So during the past 12 months, he had 3 episodes of cough with expectoration and sputum collapse. So in this PFT, if you see this FeV1 by FVC, FeV1 by FVC is 67%. And then if you look at the FVC value, FVC is normal in this patient. So is there obstruction in this? Yeah, FeV1 by FVC is 67% predicted, therefore obstruction is present. Is there restriction in this graph? The FVC is 100% of predicted, therefore there is no restriction present in this PFT. So this is the values which we see in the previous case. So what is the severity of obstruction in this? Once after seeing this FeV1 by FVC value, we have for the severity assessment we have to see the FeV1 values here. So this FeV1 value in the pre-bronchodilator is 83 and post is 88. So we have for always for grading the severity, we have to look for the post-bronchodilator value. So the post-bronchodilator value is more than 80%. So the obstruction is mild. So is there a reversibility in this? There is only 6% change here, but based on the volumes, it is this FeV1 value is given in liters actually. So this 3.13 is around 3,130 ml, and this 3,340 is 3.34 is 3,340 ml. So definitely there is a increase around 210 cc in this. So but the entire criteria of both 12% change and 200 change is not met in this. So it is a partial it's mild COPD with partial reversibility. So in case 3, a 25-year-old male referred for preoperative pulmonary function assessment. He is a non-smoker with no history of any respiratory disease, and his chest X-ray is normal. And this is the PFT value. If you see this PFT value, the FeV1 by FVC is 83, which is normal. Then FeV1 is 98% and FVC is 104%. So this is a normal PFT. So this is case 4. A 41-year-old female with no past history of any respiratory problems, and she had 5-year history of joint pains, morning stiffness affecting small joints of upper and lower arms, and for 2.5 year duration. Now presented with 2 months of exertional breathlessness and chest radiograph of diffuse infiltrates. And this is the PFT values of the patient. So this is showing FeV1 by FVC is 77.8%. So that is normal. FeV1 by FVC less than 70 shows obstruction, but here it is normal. With normal FeV1 by FVC, then we have to look for the FVC value. So FVC value is less than 80%, showing it is reduced. 73.6%, and if it is 71 for FEV1 is 74%. Therefore, restriction is present. So the interpretation from this PFT is it's a restrictive ventilator effect. And points to remember from this: it is impossible to diagnose a respiratory condition using spirometry alone. So history and clinical examinations are very important. And if the clinical picture and spirometry findings don't quite fit together well, then we have to question the diagnosis. And if the symptoms are out of proportion to the spirometry results, then also you have to question about our diagnosis. And use appropriate value for different ethnic groups. And we have to look at the numbers on the curve both. Then look at the effort and reproducibility of the PFT. We have to treat the patient and not just the numbers. The FEV1, FPC, and FEV1 by FPC ratio all are necessary to interpret the spirometry. And FEV1 by FPC reduction may be normal in elderly patients. False normalization of FEV1 by FPC can be seen in very severe obstruction, because in very severe obstructive lung diseases, the airway will react as a restrictive lung disease conditions. So those may produce some false normalization of the FEV1 by FPC. Hence, clinical history is very important in diagnosing these patients. And the spirometry which is not performed correctly does more harm than good. Thank you.
This bronchodilatory holding time is
Yes, sir.
we
Normally do it in our see when we put the patients on bronchodilators.
Yes.
They keep coming to us every 3 months or 6 months. We cannot ask them to cut the drugs and come. So
Definitely, we have to assess the patient's clinical condition. Only if he is stable, we can do that. But if the patient is still dependent on inhaler therapy, then usually we won't do for those patients. But theoretically, for a proper assessment of the airway reversibility, if we are starting a patient on an inhaler therapy, then we have guidelines is for 3 months. He has to continue the same inhalation therapy. But if we are planning to step down the inhalation therapy, or the patient is clinically better, then we can ask them to withhold the drug for a particular time, and then we can perform it. But for symptomatic patients, we won't do this.
are there any more questions? Thank you, Doc. Wonderful. In fact, this in physiology, whenever I come across this respiratory physiology, volumes and curves and all that, the chapter I normally skip it. Electrophysiology of the heart and electrophysiology of the lungs is something really tough, but you really made it look simple. And I can never forget my incident which happened to me when I was doing my third year of second MBBS. I used to carry a set and coat and all, and I used to go by bus to Stanley Medical College. So one patient got up in Alabret, and I was going fine on the bus. He showed me a spirometry and showed me that those days they used values with no interpretation also. So he gave it to me and said he thought it was original doctor without strength and all that stuff. So I kept on looking at it, this side, that side. I could not understand the rate of what was given there. So I told him, see, I have a case, I have to get on the next stop. Tomorrow you come in this bus, I'll tell you everything about this. Then on, I never got into that final bus at all from my life. So tough is spirometry. Particularly, I know GPs, they really find it with so many figures. At least now you have some interpretation. But how good this interpretation is, I'm not very happy about. Lot of every interpretation in FEU, this spirometry comes as obstructive lung disease, small airway obstruction, that's what comes. But genuinely, when you go into it, there will not be small airway obstruction. And as you rightly said, physical examination is very, very important. Without clinical examination, interpreting spirometry may not be very good. So thank you very much, Doc. Thank you very much, and maybe you can first say. Rahul, I have to say a few words. Your interaction profile is something phenomenal. In fact, all of us, you'll agree with me. So instead of keep on talking about the patient, you put it in the slide. It looks so. It's a good venture which you have done. Profile of each speaker. Kudos to you.